Chapter 18, gastrointestinal emergencies. Just like with anything else, we're going to start with structure and function, a little anatomy and physiology. So if we look at this picture here, on the left-hand side, we have depicted for us all of our solid organs. Our solid organs are going to be our spleen, our liver, our kidneys, and our pancreas. These solid organs, for the most part, have a very, very large supply of blood. When these hollow organs are damaged, they do a lot of bleeding. So lacerations and things like that to the liver, some of this sort of delves into the realm of trauma a little bit. But when we have damage to those solid organs, we're going to have a lot of problem with blood loss. Enough so that even if it is an internal injury, so one of those hollow organs decided for one reason or another to break open and spill its contents really are going to be a lot of blood. So with that being the case, our solid organs are going to be a pretty significant cause for hypovolemic shock from an internal hemorrhage. If we look over on the right-hand side, we see our hollow organs: stomach, gallbladder, large intestine, small intestine, urinary bladder. And if you look at all those hollow organs, you see that their job is more to store things. And a lot of the times, the things that which those hollow organs store are very, very detrimental when there's a problem with those hollow organs and they leak their contents. Because a lot of it are the byproducts of digestion, which are loaded with bacteria. They have all sorts of infectious problems that they're going to cause when they're not housed inside of their hollow organ. So when we have hollow organs that leak their contents, we have different kinds of pain. We have different sorts of signs and symptoms that we're on the lookout for. Our visceral pain. You remember back to respiratory, way back to yesterday when we were talking about those visceral and parietal pleuras that line the lungs. Everybody remember that?
Is that the ones that don't touch each other? Is that space in between?
Yeah. They're really close together. They don't actually touch. Well, the linings of the stomach or the abdominal cavity are the exact same way. We have a visceral peritoneum. That visceral peritoneum is the lining of the actual outside of the organs themselves. We have a parietal peritoneum, which is the actual lining of the inside of the abdominal cavity wall. And that is what contains all of our abdominal contents in our abdominal cavity, keeps them right where they're supposed to be, and is the source for a lot of our pain receptors. When we speak about the visceral peritoneum and abdominal pain, we're talking about the visceral pleura. So if I have a visceral type pain, that means it is pain that has to do with the organ itself. It's very, very specific. My patient is able to point to a spot on their abdomen and say, it hurts right here. If we have a more parietal type pain, we have pain that is more diffuse and spread out. So if we know that solid organs are more prone to sort of breakage and fracture and trauma, does that sound like it would cause more visceral type pain or more parietal type pain?
Visceral.
Yeah, we're going to have damage to that organ itself is what's causing us our pain.
So that visceral is pretty much like direct pain definition.
Direct pain, absolutely. Our parietal is pain caused by one of those hollow organs leaking all of those nasty contents into our abdominal cavity, into that peritoneal space, and aggravating everything and irritating everything and causing more damage to the structures, and it's more spread out.
Good spread.
That organ is leaking, not actually broken. When we palpate our abdominal quadrants, this should be fairly similar. We have left upper, left lower, right lower. We're going to palpate the quadrants. Generally, when you're assessing your patient, we want to start in the abdominal quadrant that is further away from wherever it is they're complaining of pain. So we don't start, if they're saying, oh, I have this right lower quadrant pain, we don't immediately start palpating in the right lower quadrant. We want to start maybe in the left upper. We want to be further away from that. How come you think we do that?
Because you don't want to put direct pressure and infect an area that's hurting, and you want to feel around to see if it has spread or radiates to any other areas.
Absolutely. And the minute we poke something that hurts real bad, everything else hurts. So it does us absolutely no good, no clinical significance to poke in that right lower quadrant and then have everything else be painful. So we start further away because it gives us a better idea. It tells us if the pain radiated, like you said, Alex, and it helps us more. It's more clinically significant to palpate the other areas first, because not for nothing, if they're telling me it hurts, it's probably going to hurt more when I poke it. So it doesn't really give us all the best information when we just poke and prod and it winds up causing more pain. Our quadrants are divided by the belly button. We have one line that goes imaginary through the belly button up and down. That's our midline. And then we have another transverse line that goes either left to right or right to left. It makes no difference. And our frame of reference is the umbilicus, the belly button. So the way abdominal pain works is one of three flavors. We either have a mechanical force, so some form of stretching or traumatic event that will cause our abdominal pain. We have inflammation, which is a disease process. It is the body actually causing that inflammation or something actually causing that inflammation. Or we have ischemia. Ischemia, we just spent a really long time talking about ischemia. And it is the same in our abdominal cavity as it is in our cardiac system. It means that one of those organs in some form or fashion is not being supplied the oxygenated blood that it requires, and that tissue is beginning to suffer for that. It is really just organ and tissue hypoxia because oxygenated blood flow has been interrupted to that spot. So we already talked about visceral pain, we already talked about parietal pain, and we are pretty well versed in our referred pain. So referred pain is just that. A patient who's got sort of poorly localized pain in their abdominal quadrants that also complains of pain felt somewhere else. We see that a lot with our patient who's having gallbladder issues. So, someone who's a little bit overweight, probably a little bit north of 40 years old, and they just ate a very high fat meal. They're complaining of some GI upset. They're complaining of some right upper quadrant pain. And when we finally make our way around to palpating that right upper quadrant, they say, oh, wow, that hurts, man, my shoulder. And they complain of pain in their left shoulder. It's all just traveling along those neural pathways. And it's just really telling us that they do have some pretty significant illness or some pretty significant pain in that area specifically. Visceral pain is normally characterized as like a dull ache. It's not always really easily localized for the same reason. Now, it does have to do with that specific spot, but it originates in that spot. And because of all those nerve pathways, the pain is specifically located, dull, achy, and extends. Our parietal pain is inflammation in the peritoneal lining, and it is side to side, one side or the other generally, and it is more diffuse and spread out, and it's really intense and sharp. So inflammation of the peritoneum, peritonitis, inflammation of the peritoneum, can be caused by blood, pus, bacteria, any chemicals in there just irritating the structures of our peritoneal cavity. Signs and symptoms are going to be just that: pain in the abdomen or tenderness in the abdomen on palpation. We're going to have some nausea, some vomiting. When we talk about anorexia in sort of medical term and describing a condition, that just means your patient is going to be unable to eat. This Markle test, this is going to tell us a little bit of information, what's going on with our patient. We have them stand on their tiptoes and then drop down onto their heels. You want them to drop fast and hear an audible thump. You'll actually, now I'm not telling you that this is practical or this is even something that we do a whole lot of, because our abdominal pain patient is generally found in some way, shape, or form in this very adequately depicted position.
Fetal position.
Why do you think they do that?
Because it's the only way they're going to find comfort by bending and crunching in, because the pain's so unbearable.
Yeah, it's position of comfort. It's the only way they're going to be comfortable. It's the only way that they're going to feel any sense of relief. If we tried to lay them down flat on the stretcher and lay them out, we're stretching the muscles of their abdomen. We're actually going to make their pain worse. When we talk about transporting patients in a position of comfort, this is one of those times. This patient rarely is so sick that we couldn't transport them on the stretcher laying on their side like that so that they would be more comfortable. Abdominal pain on palpation, widespread, is going to tell us possible peritonitis. I'm going to start you guys off with a question. Regardless of the cause of our abdominal pain, what do you think our treatments will be? What do you think our end result here is going to be? You have all your medications. Can any of them treat abdominal pain?
No.
It'll be transport.
Transport, what are we going to monitor?
Blood pressure, ABCs.
Bingo. ABCs and vital signs. We just talk to our patient about their abdominal pain, OPQRST sample. We're really just working it right forward and backward. And at the end of the day, make your peace with the fact that really nothing you're going to be able to do for this patient is likely to actually physically make them better. Because who's going to make them better? Most likely a surgeon or somebody who's going to prescribe them some sort of antibiotic or anti-inflammatory to fix their inflammation or stop their bleeding or remove their sick appendix. Because appendicitis is inflammation of our appendix. We call it one of the more likely causes of the acute abdomen when we talk about right lower quadrant pain. Acute really just means emergency, so we have an emergent abdomen. When the appendix is inflamed, children are our most likely age group for this, because the wall of their appendix is actually thinner. So that inflammation will cause it to thin out more and thin out more until eventually it ruptures. And it's a hollow organ, so when it ruptures, it's going to spill all of that abdominal content from back when, people were cave people and we used to eat raw meat, because that's what the appendix was for, to help break down raw meat. And spilling all of that stuff into the peritoneal cavity is going to cause inflammation and cause irritation, and it's going to cause pain. Our patient who is like the stereotypical appendicitis has abdominal pain or cramping in the right lower quadrant, some nausea and vomiting, fever, lack of appetite, and guarding. Guarding is what this patient is doing right now. She is doing anything and everything to keep us away from her belly, because her belly is very, very sore. If my patient were found in this position and was guarding and trying to keep me away from their abdomen, I may not even palpate it, because what's the sense?
Yeah, it's gonna be more pain.
Yeah, does it look like it hurts?
Excruciating.
Yeah. So why do I need to go and make it worse? There's very little, right, that we're going to find out from increasing this patient's abdominal pain. That's why I think there's probably a question that you'll see at some point. I don't remember on what, probably this quiz maybe, or maybe the module exam. And it asks you like what you would do for a patient who's having this kind of abdominal pain. And a couple of the answers are like, I would vigorously palpate the patient's abdomen. It's like, wait, are you crazy? The answer is yes. Would we palpate if we had to, if we felt like there was some sort of significant question I could answer by palpating this patient's abdomen? Sure, I'd do it.
But not vigorously. You're not gonna like.
Right. I'm not out to cause this patient's day to be worse. I'm just trying to see if the ends justify the means and see if I'm on the right track. Moving on along, we're going to talk cholecystitis. Does anybody remember from a few days ago? I believe it was probably the human body, chapter 6, when I said what cholecystitis was.
Inflammation of the colon.
Close. It would be nice if medical terminology always worked like that, wouldn't it? So it's inflammation. You got that part right. This is inflammation of our gallbladder. The gallbladder's technical name, I guess, would be cholecyst, because it is, what did they call it? Why, I don't know. It seems much easier to just call it a gallbladder. So inflammation of our gallbladder can be associated with gallstones, can happen to anyone, but it generally is women between 30 and 50 years old are our real typical gallbladder inflammation patients. The gallbladder is a storage depository for bile that helps our stomach break down high fat content meals. So if we have blockage of those ducts that allow the bile to get out of the gallbladder and into our stomach to help break down something with a high fat content, the bile is still going to be produced when we eat something that is in a high fat content, but it's not going to go and help. So we're going to have some indigestion. We're going to have some right upper quadrant pain. There's generally a lot of pain on palpation and a lot of referred pain to the opposite shoulder. Our patient's going to complain of some significant indigestion, like constant belching or heartburn, maybe some nausea and vomiting. If they do vomit, it's likely to be greenish in color because it's bile, and bile is green. So people over the age of 30 to 50, after a high fat content meal, people that are generally a little doughy around the middle, are going to be the patients who we really think of when we think possible gallbladder attack and possible blockage of the gallbladder from accomplishing its mission. This is one of the bigger ones we'll talk about. GI bleed. A GI bleed can occur anywhere in the gastrointestinal tract. The causes of possible gastrointestinal bleeding are innumerable. They could be just about anything. But let's talk about how much blood is actually involved in the 40 or so feet of intestine that we have inside of us. Every single bit of our gastrointestinal tract is lined with a mesh of capillary beds and arteries and veins and all sorts of vasculature. So if our gastrointestinal system decides that it's going to start bleeding, it has an almost unlimited amount of blood supply and almost an unlimited amount of ability to cause undiagnosed hemorrhage. We may never see a drop of blood, and our patient will have a pretty significant GI bleed. Age groups for this are generally around 40 to 70. Some of our common signs and symptoms are going to be, well, abdominal pain and tenderness, vomiting of blood, that's hematemesis. We have melena, which is the passing of black tarry stools. And hematochezia is the $10 medical word for vomiting coffee ground-like substances. Your blood is red in color. Your blood is red in color because it has a lot of iron in it. The iron, specifically the red blood cells, is not very well digested in your stomach. And when a patient has an upper GI bleed, that blood gets down into the abdomen, into the stomach, and the stomach acids can't break it down. So when our patient will vomit that substance back up, it looks like what would come out of a used coffee filter. And you know what? I actually just made a mistake as well. Hematochezia is fresh blood in our stool. Melena is black tarry stools. So hematemesis is vomiting that coffee ground substance. Hematochezia is fresh blood in the toilet. Melena is black tarry, sticky looking stools. The reason these three things are significant is because that's going to tell us a little bit more about where the bleed is. If my patient is vomiting something that looks like coffee grounds, I know that it's got to be an upper GI bleed. If my patient is passing fresh blood in their stool, I know that it's got to be way down in the gastrointestinal tract, because the lower portions of the gastrointestinal tract are no better at breaking down blood inside of them than the upper portions are. And then if I see that melena, that black sort of, it's really kind of awful looking when the patient has a bowel movement, that means, again, that it's a little higher up, but it's below the stomach. It's significant just based on the fact of, let's look at it sort of logically here for a minute. If my patient sees fresh blood in the toilet when they use the bathroom, and it's a lot, because it can be a lot, are they likely to call 911 pretty close to right away?
Absolutely.
No.
I'm going to go along the lines of, if I saw a ton of fresh blood in the toilet when I went to the bathroom, I would be more likely to seek medical help. That black tarry stool, that's something that's a little bit easier to overlook and not necessarily notice right away. So the further up in my GI system that bleed is coming from, that black tarry stool is generated, you may not even notice right off the bat. So that tells me that that probably got the opportunity to go on for a little bit longer. And either way, at the end of the day, this is going to lead to hypovolemia and shock. We're likely to see pale, cool diaphoretic, changes in my patient's mental status, weakness, unexplained syncope. Your patient has a bowel movement, goes to get up off the toilet and falls and whacks their head on the wall because they have passed now so much blood and they had such a significant leak that they're hypovolemic, and when they stand up, their blood pressure dips and down they go. So be on the lookout for some pretty significant signs and symptoms of shock to anyone who has a complaint that sounds anything like a GI bleed, because it is entirely possible for someone to circulate much of their circulating blood volume into the toilet or into a basin because they're vomiting and never see or even really know or have been diagnosed with any type of bleed. We're going to likely to see very low blood pressures on these patients. The one thing with GI bleeding is it can be completely and absolutely pain-free. There may be no pain, no tenderness, no swelling, no distension. These are all the things that we're looking for in our patient's abdomen: pain, swelling, tenderness, distension. We may have not one bit of that, but our patient is just pouring blood out. I mean, one of the ones that sticks out to me is I responded to a call for someone who had an active GI bleed. And when we got there, there's this little old guy sitting on the edge of his bed, gray as can be, still conscious, still alert, very low blood pressure, very tachycardic. And when I opened the door and looked into the bathroom, it looked like someone had been exploded in this bathroom. There was a halo of blood around the toilet. There was blood on the wall. There was bloody handprint. There was just blood everywhere. It looked like a murder scene. And I could not even fathom the amount of blood that this patient must have lost. And still just sitting on his bed, looked like shock, was probably in shock, but still talking to me, still maintaining his own airway, still breathing, albeit fast, still circulating blood, albeit a whole lot less of it. And it just was one of those things like, this is truly hypovolemic shock looking back at me. And it's from something like he just had a major explosion when he went to go use the bathroom. So we're going to skip through a little bit of this and we'll get right down to assessment, because assessment is where it's at here. Talking about scene size up, we'll take this as we would any other call. We're looking for scene safety, mechanism of injury, nature of illness. We're going to look around the scene for clues. We're going to see if clearly my patient is found in this position. I can pretty well decide that she's having some sort of abdominal pain. I'm starting to get my general impression. What is your general impression of this girl here on the floor?
Tommy, I lost the slides.
Yeah, I did too.
That's because I didn't press play again. That better?
She's definitely in a lot of pain. Abdominals are probably cramping up very tight.
And really, at the end of the day, we're still just talking general impression, right? We're doing our scene size up. We're getting ready to kick off our primary assessment. You know, if I'm expecting a whole lot of nausea and vomiting and splatter and gross, I'll probably throw some eye protection on, because fool me once. Look around the scene for clues. What I can tell you is the first time you respond to somebody with a lower GI bleed, you'll never forget the smell. It gets into your nose and it just stays there. There's no getting rid of it. So use all your senses. See if there's anything that, you know, is pointing you towards what's going on as you approach your patient. We get into our primary assessment. Here's our general impression. We're looking at this patient laying on the floor, obviously uncomfortable. She's guarding her abdomen. This is not standard operating procedure for the way a normal human does things. I'm still going to give consideration to, was this patient a victim of a trauma, and do I need to start thinking about maintaining her cervical spine? So do I need to dedicate somebody to holding her head still? How can I get the answer to that question?
Asking the patient.
Yeah, I'm starting to do my AVPU. I can start asking her questions. You know, maybe she's on the ground with her eyes clamped shut and I have to announce myself. But if she's conscious and alert, when I announce myself, she's going to continue the interaction. It's not somebody where I have to go, hey, wake up. You got to keep talking to me. I got to ask you some questions. So I do my AVPU. All right, cool. She's alert. I'm able to say, hey, did you fall? Did you somehow get injured? Or is this, you know, not that kind of complaint? Are you having abdominal pain just because you're having abdominal pain, not because something happened to your abdomen? And that'll tell me, do I need to manually stabilize the C-spine? If the answer to my trauma questions is no, I'll get right back to my AVPU. Okay, well, I know she's conscious and alert. I'm going to ask her to make sure she's oriented, person, place, time, and event. I'm going to make sure that I pay due diligence to my ABCs. I'm going to make sure that her airway is open, clear, and secure. If she's talking to me, I know her airway is patent. I move right into breathing. Rate, rhythm, quality. I want to know too fast, too slow, just right. I want to know regular, irregular, and painless, effortless, noiseless. Do I want to know that her respiratory status is intact? I go ahead and get out my stethoscope and I'm listening to make sure I don't hear any crazy noises coming from her breathing. At this point, she's either bringing gas in well enough or she's not. If she is, high flow O2, 15 liters per minute with a non-rebreather mask. If she isn't, I'm going to ventilate 1 breath every 5 or 6 seconds with the BVM connected to oxygen at 15 liters per minute. Then I move right on to circulation. I'm going to check radial pulses if she's awake. I'm going to check radial and carotid if she's not. I'm going to look for rate, rhythm, and quality here. Too fast, too slow, just right. Regular, irregular. Is it strong? Is it weak? I get my skin color, temperature, and condition. Depending on what I think is going on with this patient, is going to tell me what I expect to see for skin color, temperature, and condition. If I think there's some sort of bleed going on, I start really looking hard for signs and symptoms of shock. I have to really convince myself that this patient isn't in shock before I decide that they're not in shock. Why? Because it is one of the most important things I can recognize early in the game and start getting on the business of getting squared away. And I can do it just by looking at her. I'll give her a quick sweep for any gross hemorrhage that the carpet or her clothes might be hiding from me, and I make my transport decision. She's going to be a high priority transport to the closest appropriate facility with an ALS intercept en route, and then I move on. I'm going to do my evaluation. I'm going to get my history of her present illness. I'm going to get her medical history, so my OP, QRST, and sample. My physical exam is when I'll start palpating the abdomen, looking for any involuntary guarding. So when I push something, does she try and swat my hands away? I'm looking for rigidity, distension. I'm looking for voluntary guarding as well. Is she trying to just do anything, move, shift in position, use her hands to block my ability to palpate her abdomen? How bad does it hurt is what I'm getting at here. And where does it hurt? Once I've done that, I get my baseline set of vital signs and I move on. What is my treatment for all of these umbrella terms that we'll call the acute abdomen or whatever you want to refer to it as? I'm going to treat her airway, breathing, and circulation. I'm going to put the patient in a position of comfort. I'm going to administer O2. I'm not going to give her anything by mouth because I don't want to make any of these things worse. Reassure the patient. Be there for the patient. We're going to treat for shock aggressively all the time, and we're going to transport. That really is the long and short of it. When it comes time that I have finished everything, I go right back to the beginning. Done and done. Document and record everything. I go all the way back to my primary assessment. I make sure that the primary assessment is all nicely packaged up and working the way that it's supposed to. I work my way back through some of the history of her present illness. Maybe I poke and ask a few more questions. And then from there, I reassess my vital signs. And by the time I've gotten that second set of vital signs, guess where we are?
At the hospital.
At the emergency room, and I'm giving a report to a nurse, and she's going to get some definitive care and some definitive treatment, and they're going to take some images and some lab work and do all the things necessary to fix whatever is causing her abdominal pain. whether it's going up to surgery and having an appendix removed, whether it is just going and getting some antibiotics and a little bit of hydration because my patient hasn't wanted to eat for the last day or so. Que sera, sera. Downstream is downstream. Whatever they find, they'll fix for real when we get to the emergency room. Sometimes our job is just to not let anything get any worse. Anybody got any questions?
So it seems like with the GI, we're always going to be, like most of the cases, just resorting back to our ABCs and OPQRSTs and sample, and
Yep.
pretty much just get them on this, sling them in, sling them out.
Yep, and these are patients that will get a little bit more of, okay, yes, we do the verbal exam for a lot of medical patients, but these are also patients that will get a bit of a physical exam. We're going to do a bit more of a focused exam to see if we can start figuring out at least what organ or what portion of their abdomen is causing trouble. Because if you find problems in the upper quadrants, you know that those problems are going to be associated with hemorrhage, and hemorrhage is always bad. If we find problems in the lower quadrants, now we're thinking spillage, and spillage is clearly not good for the patient. It's likely to cause all sorts of inflammation, irritation, pain, and infection, but infection isn't going to kill them as fast as bleeding to death is. So that means I have time to work. I have time to play with and get this patient in as good a shape as they are and make them stay that way by focusing on their vital signs, assessing and treating airway, breathing, and circulation, and looking for those little things that push me towards the idea that my patient might be going into shock. All right, fellas, that's what I got for you today. Tomorrow we'll do neuro and whatever else was on the books, and that should catch us up to right where we need to be. If you guys don't have any questions, then I don't have any answers. And I'll see you at 1 o'clock.
All right, thanks, Tom.
Yep, no problem. I'll
Thank you.
get these recordings up, and then tomorrow we'll probably have to stop the lecture in the middle again so that I can get all the recordings in the right spots, but we'll cross that bridge when we come to it.